Good evening, everyone. My name is Heidi White, and I am the Group Fitness and Wellness Manager at JCC Greater Boston. Special thanks to Beth Israel Deaconess Needham and Beth Israel Deaconess Medical Center for their partnership and for helping to coordinate the Wellness Speaker Series, including tonight's topic on why wait, outsmarting your physiology with or without GLP1 medications with Judi Townsend. Judi Townsend is a practicing physician assistant in medical weight management at Beth Israel Lahey Medical Center. In 2007, she began working under the tutelage of Dr. Louis Aroni from the Comprehensive Weight Management Program at the Weill Cornell Medical Center in New York. Early in practice and prior to recognition by the American Medical Association, Judi readily supported the idea of obesity as a disease state, requiring integrative medical treatment and lifestyle management. She has co-authored with Dr. Aroni in the textbook, Understanding Obesity, Biological, Psychological, and Cultural Influences. Judi is also a practicing licensed marriage and family therapist, with a focus on disordered eating and transgenerational family patterns. Judi is also certified in exercise physiology by the American College of Sports Medicine. And before I turn things over to Judi, I just want to let you know that we're going to be using the chat function at a couple times during Judi's presentation. And then at the end, we will also use the Q&A feature for your questions, and we'll get started. So Judi, I'm going to turn things over to you.
Okay, and I want to thank the JCC for inviting me tonight and hosting this webinar on what I think we all know is a very timely and important topic. And I know that a lot of people make thwarted efforts to lose weight, and it's very frustrating. And I don't believe that there's really there's a lot of information that is not been disseminated to just your average person that's struggling with weight. I've been working in obesity medicine intermittently since 2007. I took a long hiatus and I worked in various specialties, and I came back 2 years ago because I felt like I was putting sort of little Band-Aids on very big wounds, and felt like obesity, by starting going back to obesity medicine, I was going to help people prevent the initial injury in the first place, and much more satisfying and meaningful. We know that treatments are, first practice, the treatments for obesity have come a really long way since 2007, but so has our understanding of the whole weight regulating system. And by understanding that, we have a lot of tools now to help people with weight. My hope is that, at Beth Israel, we believe that knowledge is power. And my hope is that what you learn tonight and next week, if you decide to join, is going to leave you with some confidence that there's a lot that you can do to affect your weight, or anyone can do to affect their weight trajectory with or without medication. I'm going to encourage you to ask questions in the chat. I'll do my best to address all of them. I'll do it at the end of the talk. And then I have some questions two questions that I'm going to put out there to you, and it'll be helpful for you to answer as we start to, that'll help move the webinar along, and I can get a sense of what your thinking is. So the first question is, I'm wondering, I think I can get to the chat, is who do you think that obesity from what you know so far is, do you believe, do you think, is it new to you that obesity is a disease? And if you could, anybody put an answer that, and I'll go from there. I'll give you a minute. Okay, it is a disease. No one else. Everybody's shy. Yes, okay. That's 2 people. Yes, it is a disease. I'll give it another few seconds. Okay. So yes, it definitely is. And in 2011, it became a board certified specialty. And in 2013, it was declared a disease by the American Medical Association and by the Center for Disease Control. And it's been a really important declaration because it's allowed private and public money to be put into research, which has led to the medications that we're now using, probably really the first generation of medications that can affect a significant amount of weight loss. And it's also been a driver for insurance companies to recognize that it needs to be covered. That seems to change day to day right now, and some of you may have had that experience. Something is covered, it's not covered. It's a difficult process because these medications are generally meant to be taken long term. We don't yet know how, I'll talk more about the medications towards the end, but we don't yet know how what that's going to look like. So, sorry, let me just, okay. As we said, it certainly is a disease, and not only is it a disease, it is responsible for more than 200 weight-related complications. Obesity is probably, I would say with the rare exception, you could call it pre-diabetes because that is what it ultimately leads to. It's harder for me to come up with a common diagnosis that's not related to weight than one that isn't. What we know is that there's pear-shaped weight, people with excess weight where it's pear-shaped, and some where it's more of an apple shape. And we used to think that the visceral fat, the fat around the middle, was inactive. It just kind of sat there. It was stored tissue. And what we now know is that it's metabolically very active. And what it does is it produces a lot of nothing you need to know, but proteins, and we call them cytokines, and things that are really damaging to other tissues and other organs in the body. And then there are actually good things that come out of some of our cells that can help lower cholesterol, and it seems to get in the way of the body producing those good things. So it is, again, it's been referred to as a fat storage disease. It's been referred to as a disease where there's dysregulation of, I'm talking to people on so many different levels. So sometimes I go over, sometimes I go under people's understanding. So I'll give a lot of definition to what or ways I'll describe things in many different ways. So let me go to let me go here first. So it's a really, as we said, it's a really essential disease to be treated, and we can minimize what we're seeing is diseases in every single specialty. My next question is, who do you want you to think, put in the chat if you think that this is a disease that can be overcome with willpower? Anything? Somebody has to answer. Okay, nobody? Okay, I think willpower is part of it. Okay. You don't think so? Okay. So, and I want to say this, let's know that our definition of willpower, if anybody else still wants to answer, is the ability to control your own actions and thoughts to pursue long-term goals. Let me move this. One second. Often resisting short-term temptations in order to achieve these goals. Okay. Well, what we do know, there might be an element of willpower, but there are so many hormones and pathways in the body that control appetite and satiety that are dysregulated and will overpower what our cognitive brain knows to be right. And what I was saying also in terms of the disease process and the what comes from the visceral fat is that it's as much, we believe it's as much of an endocrine organ as the thyroid, the testes, the ovaries, that there's just so many hormones coming out, and again, not helpful ones like there are in the other endocrine organs, including the pancreas. So if you had any thought that it could be willpower, maybe this will make you think again. So in 1975, a little more than 10% of people were obese, okay? And as we go up to 2016, we can see that over 35%, it's closer to 37% of people were overweight. And to think that there could be such a consistent upward trend is unusual. If you think about overdose deaths, if you think about suicides, if you think about depression, if you think about there's many diseases where you would see some ebbs and flows over time, maybe related to the stock market, maybe related to COVID, related to a lot of other things that are happening, but there are very few diseases where we see this kind of consistent increase. We also know that that only goes to 2016, but we know as of 2023, over 40% of people are considered obese, and that would be a BMI of 30 or more. And you want to think about also with willpower, we know that there are people who are struggling with weight but have put their mind to starting their own business. They have a startup that's been successful. They have had a family. They've created art. They've done all kinds of things that most other people can't do. But the one thing they can't seem to manage is their weight. And if you look at even Oprah Winfrey, for example, she's a billionaire. She's one of the most influential, one of the most successful people in the world. they say, and she's not been able, well, finally, she's been able to lose weight with the newer drugs. But I would say, looking at what she's been able to accomplish, that I don't think she has a lack of willpower. So again, goal setting, planning, decision making, that's all. I think most people are capable of that, but it's this override that I'm going to explain as we go further into the webinar that doesn't allow a person to use the cognitive part of their brain to make decisions. Okay, so good news, you might find this as a bit of a relief. There's a newer paradigm for the disease, and what they think, it's not for everybody, but in biologically susceptible people, and we'll go into what that means. The thinking is that it's not that overeating necessarily causes obesity, but that obesity actually causes overeating. What patients will come in and say, the two things I hear the most is the patients will talk about food noise, this inability to really think about a lot of other things, or not to have an extended period of time where they're not thinking about food. And also a feeling that patients will say they never feel full, or they feel full and it's for a really short period of time. So what we know is that the body has a set point. It's a predetermined range that your body, we'll talk about genetics. And how big you're going to be, there's a range, is somewhat predetermined. Of course, it's an evolutionary advantage. We're essentially running on the same software that we've been running on since Paleolithic times. It's time for an update, but doesn't look like that's going to happen. And our bodies were created to withstand long periods of time where there was feast and famine, right? It could be months, it could be weeks, it was unpredictable. And the idea was the body developed not just pathways, but backup pathways that would ensure that we would be able to store enough fat that could carry us through periods of famine. Unfortunately, there is an asymmetry in terms of the body tends to, if you're not struggling with weight, if you're not one of those people that has a propensity to gain weight, they'll stay in a pretty narrow range. You might go out to a party for Christmas, for Hanukkah, and you might eat a lot over a period of a week, and then the next week you start to drop weight and you are back to the weight you've been carrying for probably many years. So the body keeps you in that range, but it does tend to favor weight gain. And the reason for that is, again, there's chances of famine. And somebody who's underweight risks maybe not ovulating, not being able to pass their genes on to the next generation, and again, survive long periods. But it also does that your body doesn't let you get very thin typically, because you need, of course, to stay alive, but you need to be able to run from predators. You need to be able to do anything that was required millions of years ago. So in terms of the genetic predisposition, there's many set points. There's when you're born, then there is the perinatal period. There can be early childhood experiences, there could be children that are exposed to radiation, chemotherapy, antibiotics, steroids when they're growing up. There may be food scarcity. That can set a child up for later obesity. Our body it's a homeostatic mechanism. And what the body says, let's take John, and John is 400 pounds. And he may have a fatty liver, he may have diabetes, he may have a father who died at an early age of a heart attack. Your body doesn't know that. What your body knows is, it says, John, let's say John is 45 years old. It says, John, I've kept you alive at this weight for however many years. So clearly you're still up and walking. So this must be a healthy weight for you. So, John, don't you worry. If you start to lose weight, will make sure that I will do everything in my power, and I have a lot of power to get you back to that healthy weight, which becomes your new set point. And again, the body does that with all these, and we'll talk about it as we go through the webinar. There's a lot of very powerful hormones and weight regulating systems in the body that keeps your body going back to that weight and makes weight loss very stubborn. So a lot of people ask, can you reset your weight? Yes, you can. The idea is that weight loss needs to be slow. You don't want to alarm the body. You want it almost to lose weight. I say to the patients, kind of under the wire, sort of quietly, before your body says, oh my gosh, what's happening? So again, slow and over the long term seems to be best. We say there's some intuitively, this makes sense. Nobody knows for sure. But one thought is your body will typically, with the medications in particular, allow you to lose about 20% of your body weight. And some thought is that you take off 10% of your body weight and allow your body to sit at that for 6 months, maybe a year, before you then attempt to lose the second 10%. It's not to say that some people don't lose more than 20%. I have many patients who have, but it's more common. It's the most likely amount that most people will lose. Without medication, it seems to be 5%. With surgery, it tends to be 30% weight loss, but the medications that are up and coming, it's looking like they will allow people to achieve a 30% weight loss. So that's just, about lowering your set point. Again, slowly, don't alarm the body. So a lot of people ask if weight is genetically determined. There are definitely genes that there's about 400 genes that are related to weight. Unlike if you have blue eyes, or I don't know, you have small earlobes, that's based on a small sequence of DNA. When it comes to weight, it's a it's a complex and very, again, large number of genes. And blue eyes and small earlobes, those genes can't be turned on and turned off, but the genes for weight can be we call it methylated. They can be changed. They can be turned on, turned off. And that's what's epigenetics is. And what can turn these genes on and off is our environment. And so we're going to go through, I'm going to give you a bunch of, well, first I'm going to flip through a bunch of slides. You don't have to even just take a quick look at this. Nothing to know, memorize, but I'm going to touch on a lot of this, but just to give you an idea of how complicated the weight regulating system is. It's everything that's in this slide and more. So it goes back to willpower. If you think it's willpower, I'm not so sure. What we say is that we live in a pretty obesogenic environment. And this is pretty much the opposite of the way we're living now, right? You had to go out, you hunted animals, you hunted your prey, you climbed trees to get your fruits and berries. You in the time of in Paleolithic times, people walked 10, 15 miles a day with all kinds of tools on their back. Then once they found their prey, they had to slay it and cook it. And so there was a lot of activity, and which we don't have anymore. So how obesogenic, I'm going to first tell you, is our environment. Everything from regulation of temperature. It used to be, well, when you walk into a room now in the summertime, it's just the right temperature. It's not too hot. You don't sweat. And in the winter, when you come in to work or wherever you're going, the grocery store, you're not sweating. It's just the right temperature. So that's one way that we are not we're not having to expend energy. We have a remote control you can heat up your car before the newer ones, before you even get there. You don't have to get up and change the channel on your TV. You have a remote control. You don't have to get up to turn the air conditioning on even. You can just click it on. But you don't have to walk around a grocery store. I certainly don't walk to the grocery store anymore, but you don't even have to walk through the grocery store between DoorDash and Uber Eats and what is it? What we ordered from the grocery store, I'm forgetting, during COVID. You don't really have to leave your chair to do practically anything these days, and that's not what we were programmed for. Just a few more examples. You can go to the store and you can buy pre-chopped vegetables, pre-chopped prepared food. There's very little that we actually have to do, and that's important because in terms of energy expenditure, going to the gym is just a small piece of what keeps us healthy. We call it non-activity thermogenesis. And that's where we expend energy just in our activities that I just described of daily living. And we will talk about exercise after. Our microbiome is also really important. I think it's not really thought to be as important as it is. What we know is that there's a healthy microbiome, and that means there's good and bad bacteria. And things like antibiotics will destroy good bacteria. And even if it's not destroying all the good, it makes so that what's in your GI tract it's all the same. And what you need is diversity. What we know is that if somebody has a healthy microbiome, if I have an unhealthy microbiome and you have a healthy one, and we eat the exact same diet, my unhealthy microbiome is going to have me absorb a lot more calories from the same meal than you would with a healthy microbiome. Another thing about our obesogenic environment that destroys our microbiome is ultra processed food and even just processed food. We know that the consumer product companies go to great lengths to make sure that what they're selling you has just the right texture, just the right smell, just the right ingredients that's going to make you want more. And they spend millions and millions of dollars on focus groups. They have chemists, they have biologists, they have a huge staff of scientists that go into creating foods that you will not only not satisfy you, but will make you crave more. And I'll get into what it is that's causing craving. So I'm going to get back to that. There's also, in terms of our obesogenic environment, I call it portion distortion. You can see that in the 60s, a dinner plate was 8.5 inches. 1980s, it was 10, 2011, and 2009, it was 12. And we've really gotten to the point since COVID, I've noticed that portions in a restaurant are much smaller. And maybe you're like me, all of a sudden I'm thinking, oh, that's a ripoff. We're really used to getting big servings and being able to eat those big servings. This is an example of how things have changed. 20 years ago, a bagel, it was 3 inches. You can read this through, 140 calories. And you can see what it is today. These are really significant changes. This is pretty much double portion size what it was. And again, add to that there's a lot of artificial ingredients, things you probably can't pronounce, in a lot of these foods that are making you not feel full, even if you're eating a larger quantity than you would have 20 years ago. So in terms of what you can do to outsmart your physiology, just going to go back. Okay, so there's GLP, there's several hormones that affect your hunger and your feelings of fullness. There's a medication called, well, let's start with the GLP. So the weight loss medications is glucagon-like peptide, and that actually comes from the saliva of a Gila monster. And that's exactly what it is, which is pretty interesting, I think. So what these GLP-1 medications do is they communicate with your brain through the vagus nerve, which runs from your gut to your brain, and it sends a message of fullness. It also slows the rate at which your stomach empties, so you will feel fuller for longer. It's also, and I'll get into more detail, the kind of food you eat will affect different hunger hormones and satiety hormones, as well as what you eat and when you eat is going to be part of food intake that can help you outsmart your physiology. And then, of course, there's lifestyle changes that we'll talk about. So the medications that we use right now are the GLP-1s, like Ozempic and Wegovy and Zepbound. Well, Zepbound is a GLP-1 and a GIP. There are stimulants that's old-fashioned, but still can be helpful. Wellbutrin or bupropion something that the stimulants help. I should give you a little detail, help by raising your metabolic rate. Wellbutrin tends to help with what we call that food-seeking behavior, that person who's looking left, looking right, thinking about food, what's next. A lot of preoccupation with food, which you can call food noise. It can help with that. Topamax or topiramate is another medication that can help. It's very old. It's as old as Wellbutrin, maybe even older, but we still don't know how it works. It's a medication that was and still is given for migraine, headaches, and seizures, but in very low doses and not consistently, not across the board. It can help people to lose weight. It can help people also lose interest in alcohol for some reason. Then there's naltrexone, which blocks the opioid receptor. That's the pleasure receptor. The pharmaceutical companies have gotten smart and they've combined a lot of these medications. There's Qsymia that combines Topamax with a stimulant. There is a synergy sometimes when you put those medications together. A lot of some insurance companies don't cover them, so it's very easy to unbundle them and just give them independently, but it ends up working the same. So I said naltrexone and Wellbutrin is another combination called Contrave. That's used, and again, there's just like with the stimulant and Topamax, there's a nice, works together. It's more powerful when you combine the Wellbutrin with the naltrexone. There's also metformin. A lot of you will say, oh, I know somebody on metformin. Yes, probably you're somebody you know who has diabetes or PCOS, polycystic ovarian syndrome, maybe prediabetes, is on metformin. That helps your body to use insulin more effectively. And I'll get into why that's important. It is off-label. It's off-label because it's been around since 1957. It's probably $2 for a 30-day supply, and no pharmaceutical company is going to do any kind of studies to see how effective that is, because there would be no payoff for them. But it happens to be a very safe and very effective medication. And again, you don't have to worry about insurance coverage. In terms of the injectables, what we know, yeah, there are some risks, which you may ask me about in the chat, Q&A, but the benefits far outweigh the risks. We're thinking that it offers neuroprotection. It may decrease the risk of dementia. It certainly, we know, decreases appetite. That's in the brain. It may, in terms of the heart, it offers cardioprotection, may be helpful in people with heart failure. It can help people with a fatty liver. It seems to help the liver heal. It helps the muscle take up more glucose, which is a really important place for storing energy. Again, we said it slows emptying into the stomach through the GI tract. It increases your sensitivity to your own insulin. That we'll talk about why that's important. So it's I even have patients who have conditions that are rheumatological conditions, psoriatic arthritis, rheumatoid arthritis, and the feedback that I'm getting is that they are feeling better on the GLP. They've been able to come off their the therapies that decrease their immune system. And off that and on a GLP, they feel better than they did on any of these really, really strong immune modulating therapies. So that's, there's a lot we don't know, but I also went to a diabetes and obesity conference a couple of weeks ago, and if there was 15 lectures over each day for 3 days, I would be hard pressed to say that there wasn't a lecture that there wasn't a lecture where they didn't talk about GLP-1 medication, and none of them talked about, there wasn't anything negative said, even though, of course, as a provider, we always worry about the few things that could happen. But it was an overwhelmingly positive take on these medications. I will say one thing that's one possible problem, but should be, is being addressed, is when you take these medications, the body doesn't, it doesn't decide I'm going to take the fat and I'll just leave the muscle until, for later. It doesn't differentiate between the two. You lose both, and which is why strength training is so important. But the next generation is probably, it looks like it will be muscle sparing medication. So I hope that doesn't discourage people from exercising, but that's what's in the pipeline. In terms of, again, what you can do without medication. So protein is, there are macronutrients, right? There's fat, there's protein, and there's carbohydrates. Protein takes the longest time to digest, okay? It also, when you're eating protein, the body requires more energy through your GI tract to break down protein than any other food you could eat. It's also required to build muscle. Muscle is really important. Muscle is the only tissue, and I'll explain about insulin and the downside of insulin, but muscle doesn't require a lot of insulin to take in glucose, and that's a really important thing for weight loss. Fats take the longest to digest. Healthy fats, that's really important. There's a distinction between unhealthy fats and healthy fats. Simple carbohydrates, it's something that gives you a quick energy boost, but something you want to keep to a minimum. Complex carbohydrates give you more of a sustained source of energy. And you want to be wary of high fat, high sugar foods. That combination does something to the brain that really is similar to, they say, to crack. And so sugar is bad enough. High fat is not good, not great either, but the combination will make it really hard. Will override anything that you're thinking part of your brain is telling you to do. Also, what you should know is that vegetables, if they are either lightly steamed, raw, or lightly sauteed, they help you we all produce GLP-1 in our intestines. And you can increase, whether you're on a GLP or not, you can increase production of your own source of GLP by eating vegetables. Again, vegetables help your microbiome to diversify. It is important to, the order that you eat your food is really important. Ideally, you want to eat vegetables, then your protein, and then your carbohydrates. If you think about it, the last car on the train can only go as fast as the first car. So if your body's really busy breaking down those vegetables, the vegetables get to the large intestine, you start to stimulate already this GLP that's going to tell your brain that you're full. Then you follow it by protein that digests also very slowly and takes a lot of, we call it thermogenic, takes a lot of energy to break down. And then at the end of the meal, you have carbohydrates if you're going to have them. That's ideal, and that's what's going to keep you fullest for the longest period of time. You're also not going to get, what's important to avoid is when you have a spike of glucose. When you just eat a carbohydrate, it goes through you pretty quickly, very quickly actually, and then you end up with glucose in your bloodstream. And the body knows that it's been somehow the body knows that glucose floating around the bloodstream is not a good thing, and it needs to be stored. So what the body does is it will signal the pancreas to put out insulin. That's a great thing. Insulin in the right amount, and whatever we can't, there is no right amount. The right amount is different for everybody, but insulin, low levels of insulin is essential. If you can't produce insulin, you're a type 1 diabetic and you have to get it from a bottle from outside source. But so we need insulin to transport glucose into cells. But what can happen is if we have a lot of glucose, we're getting a big, I call it like you get a spike of glucose and a dump of insulin. And in the end, you have leftover insulin. And when you have leftover insulin, it does some of what it's supposed to do, but it doesn't want to sit in your bloodstream with nothing to do. So what it does is, one, it tells your brain, it doesn't tell your brain you want chicken, and it doesn't tell your brain you want broccoli. It tells your brain that you want the cake that's sitting over there. It wants something that it can actually work on. The other thing that insulin does is it tells your body to store fat. So it is a fat storing, it's again, an essential hormone to transport glucose into the cells, but it is also a fat storing hormone. So we don't have a test. You can check insulin levels, but it's not, if it's very high, it might give us some information, but for the most part, it's not going to tell us very much, and that's unfortunate. And also, what's a okay insulin level for one person may not be okay for another person. And if any of you know somebody or has gout, you might know that you have your friend has a high uric acid level, and somehow he's able to eat seafood every weekend, and only once a year he gets a flare. Then I've had patients where they're really strict and their uric acid level is great, and they go out once and they have anchovy salad dressing. I've seen that, and they get this horrible flare. And so you can't just go by either uric acid levels for that or insulin levels for weight. So in terms of hunger and fullness, there is ghrelin, leptin, and insulin. We just talked about insulin. And I just want to make sure that I was clear that if you have your vegetables, your protein, and then your carbohydrates, you're going to get more of your glucose levels will increase as a little bit as you are digesting your carbohydrates, but you're not going to get that spike. So ghrelin is a hunger hormone and leptin is a fullness hormone, and they work in tandem. You wake up in the morning and your ghrelin level starts to go up and you're feeling a little bit hungry, and then it's increasing a little more. And now you're feeling maybe your stomach's growling, and then you have a meal, and then ghrelin starts to go down, and then it'll go down, you feel full, and then later in the day you start to develop an appetite again. That's the way it's normally supposed to work. Leptin is a hormone that comes from the fat cells, and it sort of gives your body a sense of whether or not you have enough fat stores. And when you start to lose weight, your body says, I'm losing fat stores, things are not safe. And it's one of the hormones that will start to signal the brain to increase appetite. Again, we talked about the sequence of food intake is important. The timing of food intake is really important. Morning, we say mornings like a queen or a king, afternoons like a prince or a princess, and evenings like a pauper. You're not going to necessarily do that on a weekend, but if 80% of the time, during the week at least, you can do that, it's going to be very helpful for weight loss. We also know that a protein-packed breakfast is really, really important and affects appetite throughout the day. So what you eat for breakfast, if you have a sweet breakfast that would be the worst, but any kind of simple carbohydrates, in particular rich breakfast, you're going to start with your ghrelin levels are going to take off. They're going to end up higher each time they peak. They peak and come down, but each peak is going to be much higher than it's going to be through the day if you start with a protein-packed breakfast. Extreme hunger. You don't want to let yourself get very hungry. Some people think, oh, I didn't eat anything all day, now I'm good, I can go home and I'm okay, I can eat whatever I want because I've taken in no calories. The problem with that is if we've all done that, and you finally get to food and you eat, and you very often will have the experience where you're feeling that you're feeling fullness in your stomach, your pants are feeling tight, but you still genuinely have that sense of hunger that's coming, it's in your brain, like you feel you need to eat more food. And the reason for that is that if ghrelin gets too high, once you start eating, there's a delay in when it takes a lot longer for it to start to come down. And it makes sense, evolutionarily speaking, because if you went 2 months, 3 months without any food and you finally came across an antelope and you started to eat, it wouldn't do you much good if after 7 or 8 bites you said, I think I'm full. So also, when you wait to eat till you're really hungry, you tend to eat much faster. So again, evolutionarily speaking, if you had not had anything to eat for several months and you came upon an antelope that you could eat, there's other animals that you could be prey to, and you would need to eat quickly. So it all makes sense that what happens when you let yourself get very hungry and ghrelin levels get very high. I mentioned that the microbiome, that the healthier you eat, the healthier you're going to support the good bacteria in your gut, and you're going to absorb fewer calories for the same meal. We talked about that. I will show you some foods that can either hinder or help what's happening in your microbiome. in terms of sugary drinks. That's probably the worst thing you can do, whether it's hot chocolate or it's soda or orange juice, because not only is it a carbohydrate, it's digested so incredibly quickly. I think of it as a faucet. If you were to turn a faucet on and let the water run full throttle, and if I asked you not to let water collect in the sink, it would be almost impossible for you to catch the water coming out of the faucet and keep it out of the sink. If it was water that was dripping little by little, which can happen again if you eat your carbohydrate at the end of your meal, you would be able to keep the water from collecting in the sink. But a sugary drink goes through you incredibly quickly. Again, it gives you a spike of glucose, a spike of insulin, and it can make the rest of the day really difficult. Some of you probably have heard of insulin resistance. It's something that tends to develop over time. It's if you imagine the cells in your body, they're supposed to take in that glucose that the insulin is trying to transport, to deliver. And you can imagine maybe the cells in your body with saran wrap around them. And what happens as you become insulin resistant is there's glucose that you eat, we'll say a cupcake, and it goes through your GI tract, and then there's glucose in your bloodstream, signals the pancreas puts out insulin. Insulin picks up the glucose and it's like a lock and a key, and tries to get the glucose in, but the cell is resistant. It's not having it. It's not taking in the glucose. It'd be nice if your body could say, I already put out some insulin and I'm going to wait and see what happens. But it doesn't. It'll put out another pulse of insulin. And now you start to get elevated amounts of insulin that we talked about. We think it seems that insulin resistance develops for many reasons, but a very big one is that when you have a lifetime of sugar spikes, glucose spikes, it's again, not that you eat a donut or something over the course of a day, but you eat a large amount of carbohydrates, and that glucose spikes. Every time it spikes, you add to your risk of insulin resistance. What we know is that the longer somebody is insulin resistant, the harder it is and the longer it takes to reverse it. As you lose weight, just having visceral fat also creates a state of insulin resistance, even if you may have gained weight because you're on prednisone, or there are many reasons people gain weight. Just what comes from the visceral fat, that's again around the organs, can create a state of insulin resistance. So you really want to, if you're going to eat sugar, you want to avoid those spikes. I know we're
Judi,
running
I
out
just
of
wanted
time.
to let you know that we're just about out of time.
Yeah,
And
I just saw that we're
we
out of
have a
time.
couple minutes for questions.
Okay, I just want to say these are
Sure.
foods that you can help you increase the amount of GLP that you do produce. This is, again, these are the 3 hormones that we talked about that controls fullness, fat storage, and hunger. The last important thing is what we think also that happens is the hypothalamus in the brain is the area that controls, that communicates with the gut about hunger and satiety. And what we think is that there is inflammation in the hypothalamus. So if you covered your ears and somebody was talking to you, you're not really hearing things very clearly. And we think that that inflammation in the hypothalamus is making so that those fullness and satiety hormones that you can see they're just not doing what they're supposed to do. And we talked about insulin. A calorie is not a calorie. Even a banana is not a banana. It depends how ripe it is, how much sugar you're getting, how much carbohydrates you're getting. Sleep is really important. Strength training is essential. Again, muscle requires more energy to maintain than any other kind of tissue. Emotional eating is something that I'm going to talk about next week. Mindless eating, emotional eating, that's a big, for some people, it's not an issue, but for some people, they can lose the weight, but that becomes a big risk if they have to go off the medication or whether they're not tolerating it. Anyway, it's something that I don't think we can ignore. And it can bring a lot of peace on many fronts. And now I'm wondering if you thought it was about willpower, have I changed your mind? I'm hoping you are thinking otherwise. And questions?
Yeah, so feel free to type your questions using the Q&A feature.
And I guess you're going to get that, Heidi?
Yeah, we both will, but I'm
Okay, I'm not
but
seeing
you
it.
might have covered everyone's questions. You were very thorough. Oh, we have one here. Oh, so we have one person who said that you did change her mind a lot and has made me rethink whoops, I just lost it here. What I will wake up to and eat in the mornings.
Good.
Any questions? I think you covered it, Judy. I think, oh, thank you so much. Great. Great. All right, well, just want to say a few words in closing. Oh, do we have anything? No. Okay, hold on. I thought we did. All right. So thank you so much, Judy, and special thanks to Beth Israel Deaconess Needham and Beth Israel Deaconess Medical Center for sharing this important information about outsmarting your physiology and GLP-1 medications. So 1 week from today, on May 13th, Judy will be presenting our second topic on weight management, Beyond the Scale, Unpacking the Obesity Puzzle, covering the psychology of weight loss and management. If you would like to hear this presentation again, or if you know someone who might benefit, we will be posting the recording on the JCC Greater Boston website page on the Wellness Speaker Series page. And if you have any questions about JCC Greater Boston's programs, we have lots of strength training, cardio, we have it all. You can email me. My email is hvhite, as in Heidi White, @jccgb.org. Thank you so much. Have a great evening.